Hello my dear students, in this session I shall be covering important pathology aspects related to acute leukemia. The objective is to understand the pathogenesis and morphology of acute lymphoblastic leukemia and pathogenesis and morphology of acute myeloblastic leukemia. If you want to know the cell of origin for acute lymphoblastic and myeloblastic leukemia, you need to understand the various cells which are involved in the hematopoiesis in bone marrow. So, we have a hematopoietic stem cell here which has got the abundant self-renewal capacity. Some of them will turn into multipotent progenitors, right. They further differentiate to what is known as committed precursors, right, and then they further differentiate to mature forms. In case of acute lymphoblastic leukemia, it is at this level, that is committed progenitor level, which has got the lymphoid potential will become abnormal, in the sense there is maturation arrest and there is no further differentiation. The self-renewal capacity of those cells will increase and that results in excessive proliferation of blasts within the bone marrow. Whereas in case of myeloid leukemia, it is at this level. Usually the early progenitor which has got the myeloid potential, that undergoes a maturation arrest because of various chromosomal aberrations and it proliferates excessively, and that causes even the differentiation arrest. Okay, so that is the pathogenesis of the acute myeloblastic leukemia. So you need to know that these committed progenitors undergo increased self-renewal and there is maturation arrest. Now moving on to morphology and cytochemistry. So first you will have a look at peripheral smear examination and then you perform a bone marrow. Doing a bone marrow is very important in patients with these leukemias, because some of the leukemias can be aleukemic or subleukemic in nature. Remember these two terminologies. Means the bone marrow is packed but you are not able to see a single blast in the peripheral smear, and sometimes the number of, for example, if 20% is the cutoff, you will not be able to diagnose it as leukemia if you consider only the number of blast percentage in the peripheral smear. Because of these two reasons, okay, you have to do a bone marrow to rule out or confirm the diagnosis of acute leukemias. So what do you expect to see in peripheral smear? As I already told, with respect to RBCs and platelets, there will be anemia and thrombocytopenia. With respect to WBC, the counts are very much increased. So remember that there is leukocytosis, which is predominantly constituted by presence of blasts. Very important. So moving on to morphology of myeloblast. Now we have studied how does a lymphoblast looks. So you should try to differentiate a lymphoblast from myeloblast. So how does it happen? If you know the morphology of myeloblast, definitely you will agree that it differs from the morphology of lymphoblast. They are usually larger in size, okay, and then the nucleus is increased, but you can see the prominence of the nucleoli, which will be usually between 2 to 4 prominent nucleoli. And if you look at the chromatin, it is described as fine lacy chromatin. And in case of lymphoblast, it is going to be more of compact chromatin. Fine lacy with prominence of nucleoli is a feature of myeloblast. And cytoplasm will be more when compared to that of a lymphoblast. If it is a mature form, sometimes you will see the azurophilic granules. So MPO containing azurophilic granules can be seen as or rods. It's a very important pointer to understand or identify the acute myeloblastic leukemia. Moving on to approach to acute leukemia. So what is the stepwise approach in case of acute leukemia? This is very important to understand the whole concept. So whenever a patient comes with the symptoms of pancytopenia and clinically you are suspecting leukemia as a possibility, you will do a peripheral smear. Usually bone marrow examination is done during the same time, and if you see blasts, if it is more than or equal to 20%, next what is the line of action? You will do a cytochemical stain, that is PAS or MPO. If it is PS block-like positivity, you say that they are lymphoblasts. Further, you use a flow cytometry and also other molecular tests, and you differentiate into T cell ALL or it is a B cell ALL, right. And here, apart from MPO, right, depending on the nature of the blast which is present, you can even use this non-specific esterase, sometimes PAS in case of erythroblasts and megakaryoblast. But you have to do a immunophenotyping once you establish that there are myeloblasts which are present. Now you do a flow cytometry and molecular tests which include the FISH, PCR, etc. And also you demonstrate the genetic abnormality which is present, and then you label it as AML and also give a subtyping. So this is the approach with respect to acute leukemia. So I have already covered approach to acute leukemia, and that is the important take home from this session. Remember the morphology of lymphoblast and myeloblast and the speciality of the FAB subtypes, that is starting from M0 to M7, because questions are based on those things. And bleeding is just a non-specific manifestation, especially when the question comes as gum bleeding. Do not confuse it for tissue infiltration, okay, gum infiltration or gum hyperplasia, which is seen in case of M5 type of acute myeloid leukemia. So thank you for your attention.